So good morning all. So myself Dr. Lalit Modi and I'm presenting one trauma case. Next. So this is a 65-year-old male X-ray who has a history of trauma. He has fall from bike and got accident. And this is the X-ray of his right side. He is right side dominating shoulder. So after this X-ray, the primary doctor tried to reduce this fracture by close reduction, and then next, the impact is this one. Then he went to another surgeon and he asked for CT scan, and on CT scan the things were clear, so he referred the case to us. So if we analyze this X-ray, we will found next that there is a large tongue-sized GT fragment which is posterior superiorly moving along with 3 intra-articular fracture fragments. So it's a clear-cut articular split, and we are not able to see the anterior edge of glenoid. So we suspected bony Bankart also, and we did CT scan. And on CT scan the things are quite clear that yes, there is an intra-articular split. There is a large size bony Bankart fragment also. Next. So this is a double head sign which clearly indicates that it's a intra-articular split. Next. Along with a large anterior rim fracture. So the information with us is he is a 65-year-old male patient, has injured his right side dominating shoulder, has 4-part fracture with anatomic neck with intra-articular split, and he has anterior rim fracture which is involving somewhere around 10 to 15% of the glenoid. ARC, how do we manage this bony Bankart? Can we leave it, or we can fix it with anchor, or fix it with some screws, or directly go for coracoid reconstruction? But the problem is
so the
not a single
confusion here
case.
is the audience is obviously not decided here, because there is no consensus whether to fix it or to replace it, and on the humeral side, and similarly on the glenoid side there is no consensus. So I think it's a good case to discuss.
Yeah.
A lot of confusion and controversy.
So if we treat the fracture of humerus and Bankart individually, then definitely we have 3 or 4 options, but when there is a combination, we can have 9 options which can be suitable for these kind of the cases. We can do the osteosynthesis of humerus with leaving the bony Bankart, but in this scenario, we know that the intra-articular split is not that good that can be reconstructed well. So this option we leave. So we are leaving the option for osteosynthesis for the humerus. Then we go for the hemiarthroplasty. If we do the hemiarthroplasty and leaving the bony Bankart, then we know very well that the hemiarthroplasty with instability is one of the worst complication and definitely need a revision surgery. If we go for hemiarthroplasty with fixation with anchor, definitely this will suit to this patient. But in old patient, we have seen that sometimes the fixation with anchor is not that good. So the third option is with Latarjet. So in my mind, I have an option for either fixation with anchor or with Latarjet with hemiarthroplasty. And if we discuss about the reverse shoulder arthroplasty, then definitely the reverse shoulder arthroplasty could be an easy solution for all the problems, because it can manage the proximal humerus fracture, and with 10 to 15% of bone loss, we can do the reverse shoulder arthroplasty easily. So reverse shoulder arthroplasty could be a solution which is we can say easy for all, but in my case what I opted
One sec. Let's go back a little and let's talk about your option for the Latarjet in combination with the hemiarthroplasty, you said.
Yes, sir.
So the Latarjet was designed for bone loss. You are offering a choice of Latarjet for a bony Bankart. Now, isn't there a contradiction here?
Definitely there is a contradiction, sir, but just I told you that I have an option of either fixation with anchor or Latarjet. I kept both the options in my mind, but the bone was little bit osteoporotic, so I was not sure that these anchors they may come out. So I choose for lethargy option.
So I appreciate that, but see, the point is 65 bone loss, no, sorry, poor bones and 65 is a combination. In Indian bones, you never know what quality bones you are going to get. But the patient doesn't have any other comorbidity.
No.
So I don't think lethargy is a solution for a bony bankard. And the one message that should go out to the crowd is that lethargy is meant for serial glenoid attritional bone loss.
Yes.
And then you are substituting something there. If you have a bone there and you are going to fix it, then fix that fragment. Rather than doing a lethargy, which is not a question in primary trauma. Yeah. Your reverse will come to later. It's an ideal mix where you are provisioning for everything.
Yes.
So that's all. There is very less controversy with reverse.
Yes.
But giving a hemi and a lethargy and 2 screws in there is dicey with the lethargy. And when eventually that bone gets absorbed, because you are providing it to a normal glenoid, that except for that 5 mm rim or whatever, and those screws are going to brush against that hemi-arthroplasty. But my impression, what I have seen so far is whenever that has been done, the glenoid actually falls apart.
Agree, sir. Fully agree. So, next slide. So, what we did in this case is hemiarthroplasty for the head, osteosynthesis for fracture tuberosity, and lethargy for glenoid. So, this is a intraarticular picture which is showing that there are 3 pieces of intraarticular piece with a very less bone stock, and one important finding which is important while considering hemi, that this humeral fragment doesn't have any metaphyseal beak. So this is important point while we considering the height of prosthesis. Next. So the point which I kept in my mind is the implant height should be appropriate, the retroversion, and we should definitely have stable anatomic osteosynthesis of tuberosity to have a good results. Next. The tuberosity fixation was one of the most crucial steps. Or for that thing, we pass the sutures through the osteotendinous junction instead of directly through the bones, which are a little bit brittle. Next. And every fragment, it's a GT or LT, it should always be fixed with each other, directly with the implant and directly with the distal bone, so that there are least chances of migration. Next. Retroversion, this is important. So while rimming, we keep the arm in hanging vertical position and we flex the elbow to use as a guide for the retroversion. And for retroversion, we can ask our surgeon to measure the retroversion of opposite side humerus on CT scan. We generally keep it up to 30 degree in hemiarthroplasty cases.
So your radiologist gives you a version guide?
Yes, sir.
And so what technique does he use?
So this is difficult to tell me, but my radiologist is good in shoulder and he is really helping me.
I agree, he is helping me, but he has no surgical inclination at all. They do their own thing. We have to be in control. There are 2 different techniques and both techniques have different versions for the same patient.
Okay.
So they will give you the epicondylar axis. Okay, and that's the more defined technique in literature and that's how they are taught to do
Yes.
it. When you go in, you do a forearm axis. So which is distinct from the epicondylar axis.
Okay.
And so your measurement, you are measuring his say 33 degrees and you are using forearm axis. Even for the same patient, both these axes give you a different reading.
Yes.
So be very careful on that. That's very important because your effort should be to try and get your native version, which is again very dicey in trauma because there is no landmark there. And there's another paper that the surgeon put in a 30 degree, post-op after 6 months, the CT scan went into evaluate, it was not 30 at all in 70% of patients in trauma. Whereas in elective osteoarthritis, whenever surgeon put in 30, they had a plus minus 5 degree difference, which is acceptable.
Okay.
You understand? So even if Ashish Babulkar puts in a 30 degrees, it may not be 30 degrees. 6 months later, it will be completely different because there's a lot of gesticulation there. We are guesstimating what the version is. It may not be fully, not a high fidelity measure at all.
True, sir.
So
The radiologist.
never rely on radiologists. They are doing their job. and they are helping you. Doesn't mean that they are accurate and precise. It's our job because we are answerable. Ball should finish at our court.
But Ashish, does the version matter so much in case of trauma than in an osteoarthritic case? Because it is the position of the head in relation to the tuberosities. Now, in trauma situation, you will again be putting the tuberosities back to the head.
So Shekhar, amongst all the different factors that are going to dictate the outcome of that patient, including the size of the head, the height of the prosthesis and the version, the most critical game-changing factor is going to be version, without doubt. And I just did a BMed webinar with Alex Laderman on Wednesday on titled, Is a Hemiarthroplasty Relevant Today? And the whole topic emanated from Laderman because Laderman said the last hemi he did was 20 years back. Almost the entire Europe has stopped doing hemiarthroplasty. You have to ask, why are we still doing hemiarthroplasties? And I was actually carrying the torch for hemiarthroplasty, but my second last slide was showing how my number of hemiarthroplasties from 2010 have come down significantly by almost 70% because they fail. And if the tuberosities fail, they fail for various reasons. Poor technique on surgery, you showed the Frankels and thing, which is the right thing to do. But one of the reasons the tuberosities fail is because we do not get native version. So across this hall, if we use all our head of humeri measurements, our height of the head, our width of the head, the AP width, mediolateral width will be fairly similar. We'll have a standard deviation of say 0.5 mm. But if we measure all our retroversion angles, each of us will be different. Different from a factor of 10 to 55. What you do is you decide that I'm going to put in 20 or I'm going to put in 30, which is anecdotal. So there's a very nice paper from Pascal Boileau, which changed the Europe's attitude towards hemiarthroplasty. And he said 67% of his tuberosities fail, 40% of them were put in correctly in the post-op X-ray and they still fell apart. It's because we were using a fixed measure for everybody. So if you use that tool, then you'll be right in 30% of patients, 60% you'll be wrong, and 10% you'll be close to where it should have been. And suppose you put it in more retroversion, okay? And you put your tuberosities in, and the first internal notation he does, that tuberosity will pop off. If you put in less retroversion, the first external notation you do is lesser tuberosity is going to pop off.
That's a very important point, Dr. Ashish. So version, I think it has been highlighted very eloquently here. I think we move on because there's a lot of discussion, a lot of arthroplasty cases are going to come, and this is a very important point, and we'll deliberate on this further.
And
Please
I
tell
think-
us what
Amit, I want to ask a question here, right?
Yeah, please.
So you gave 4 choices here on this side, on your left side.
Oh, yes.
Reverse shoulder and hemi. You haven't kept the option of anatomical shoulder, and why?
Anatomical shoulder for trauma usually we don't discuss. Anatomical shoulder is for arthrosis.
Why I ask this question is, from Indian scene, somehow anatomical shoulder is vanishing in favor of reverse shoulder, even in young patients.
I think that's a discussion, sir. A very valid point.
I think I'll give him the hemi. We need not go down that because there's so much
No,
controversy
hemi
here
is
itself.
good. I'm just talking. I will also do
total
hemi.
in trauma, but total in trauma is not.
Never ever.
Sir, for total shoulder replacement in
You
this
need
scenario,
tuberosities to heal well.
we already have a glenoid bone loss. That's why I didn't opt it
So
for.
I think Raju
Yeah,
is after
give
me
you that
to
much.
finish this case and
We'll
move
stick to the
forward.
hemi.
Yeah.
We'll keep on. There'll be a lot of repetition. Cases are such that there'll be a lot of repetition. So please. Just
So this is the
last 1 minute, Lalit.
Yeah. For the right one is the intraoperative X-ray, which is shown in Siam, and this is the immediate post-operative X-ray, where we try to restore the tuberosities. And this is the X-ray after 4 months of primary surgery, where you can see that the greater tuberosity is little bit migrated, and this